Occupational English test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with the information you hear. Now look at the notes for Extract 1.
Extract 1. Questions 1 to 12.
You hear an obstetrician talking to a patient called Gabby Simcox.
For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Gabby.
Hi, Dr. Stevenson. How are you?
Good. Congratulations on your pregnancy.
Thank you.
Yeah, so now I'm one of the obstetricians here. You'll probably be seeing quite a bit of me during your pregnancy.
Do I see you each time, or will there be a few obstetricians?
Well, there are a few obstetricians here, but usually, yes, you would see me each time.
Okay.
Just depends on which days and who's about. Yeah, it'd probably be me.
Okay, great.
So I've had a look at your file, and I'm here to answer any questions that you might have, and generally just to help you through your pregnancy, okay?
Thank you. I do have a lot of questions.
Well, I can see that.
Yeah.
Fire away.
Great.
So now this is your first pregnancy.
Yes, it is.
Okay, so just to clarify, you've had no miscarriages, because sometimes people don't consider these as well.
No, I haven't.
Okay, so now just with your due date and things, let me just find out, when was the first day of your last menstrual period?
It was about the 24th of March.
Okay, and do you have a regular cycle or an irregular cycle?
Yeah, no, it's regular.
Okay, it's regular. How many days?
About 27?
Okay, that's fine. I mean, we'll work that out for you and we'll give you an exact date. Can I just make sure, has your midwife arranged your 8-week ultrasound already?
Yeah, we had that, although I don't know if it was 8 weeks. Let me just think. It was Mum's birthday on the 1st, so actually, yeah, it would have been about 8 weeks.
Okay, so we'll get the results of that, and we'll also give you an accurate date.
For the due date, yeah?
Yes, the due date as well.
Okay, so how often is it actually on the due date?
Hardly ever.
Hardly ever, okay.
I mean, it's not like, it can happen, but it's very rare.
Okay, so before?
But your due date's actually a month, so anywhere from 37 to 42 weeks. So the due date is really definitely an estimate.
Okay, so really it's kind of 2 weeks either side of the due date.
2 weeks either side of the due date.
Okay.
And any problems at all falling pregnant? You had no fertility problems?
Well, I'd been on the pill for about 12 years or something, and we thought it would take a long time, perhaps. But when I went off it,
Sure.
Yeah, the first month.
Okay, yeah, that's fine. So I can see from your file that you have a family history of diabetes.
Yes.
But you don't have a history of any hypertension or cystic fibrosis.
Nope.
Okay. The allergies part in your file was blank. Are there any allergies we should be aware of?
Yeah, actually, I'm allergic to nuts.
Okay, just peanuts or all nuts, do you know?
I'm not sure, actually, but to be honest, I just tend to avoid all nuts.
Okay, I'll add that to your file.
Thank you. Yeah, so one thing that I had wanted to mention is that I recently found out my blood type is Rhesus negative.
Okay.
Yes, so I just wanted to talk about that a little bit because I have heard that it can be dangerous if my blood mixes with the baby's blood, if the baby's blood is different to mine.
Have you had any bleeds?
No, I don't think so. Is that something that I should be looking out for?
Yeah, certainly. Look out for bleeds, and they'll also pick it up in your scans. If you notice any bleeds and if the blood is bright red, come to the hospital immediately for treatment. We'll give you an injection called anti-D, and it will essentially prevent any harmful effects to the baby.
Okay, so an injection of anti-D, that's all I need to do then?
At this stage, yes.
Extract 2. Questions 13 to 24.
You hear a physician talking to a patient called Jamila Begum.
For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor.
Hello, Jamila. Can you brief me about your health issue?
Yes, doctor. Actually, I approached a physician about my abdominal pain 8 months back. On my chest x-ray, I had a possible infiltrate, and he thought that I might have pneumonia, and I was treated with some antibiotics and prednisone. However, the symptoms improved for a short period only, and it didn't cure my disease completely. Besides, my pain had worsened by the end of the month, and I was admitted to an emergency ward. This time my chest x-ray was compatible with pleurisy, and I was treated with Percocet. However, I was given another prescription for Ultram since I had nausea and was vomiting with Percocet. Eventually, I was referred to another doctor and was diagnosed with splenomegaly. A repeat ultrasound showed an enlarged spleen of 19 centimeters. My positron emission tomography scanning showed diffuse hypermetabolic lymph nodes of 1 to 2 centimeters diameter and an enlarged hypometabolic spleen. Finally, I had my lymph node biopsy on the right side of my neck last month, and mantle cell lymphoma was detected. 2 weeks ago, I had a bone marrow biopsy that showed involvement of bone marrow with lymphoma and also circulating lymphoma cells on peripheral smear.
And your age?
45, doctor.
Okay. What medications are you taking?
Estradiol, prometrium, 200 milligrams, Ultram whenever I get pain, baby aspirin, Lunestra for sleeping, and iron supplements.
Are you allergic to any medicine?
No, doctor.
Tell me about your previous medical history.
Yes, doctor. I got my tubal ligation in 2001, and a cyst from the left side of my neck was surgically removed in 2005. I had tonsillectomy, and I get occasional migraines.
Do you smoke or drink?
No, doctor.
May I know your job profile?
Well, I'm working as a project manager.
Tell me, is there any family history of diseases?
My father had emphysema and colon cancer when he was 68, and my mother has hypertension and arrhythmia.
Well, your heat diagnosis shows the oropharynx is benign. There is shoddy adenopathy in your neck, though, and your abdomen is soft and non-tender, and shows the palpable spleen approximately 10 centimeters below the right costal margin. Your mantle cell lymphoma is confirmed, And I would advise that you should go for chemotherapy with hyperfractionated cyclophosphamide, dexamethasone, doxorubicin, and vincristine. Discontinue aspirin for now and continue estradiol and prometrium. Take Ativan as and when you feel anxiety. You'll be given allopurinol from today and hydration further so that you can avoid tumor lysis syndrome. I will plan to add Rituzan a little later on in your course since you have circulating lymphoma cells, and I'm planning to get you evaluated for bone marrow transplant in first remission.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen.
Now look at question 25. You hear a discussion between 2 doctors about the complications which are expected at a later stage following heart attack.
Hello, doctor. What types of complications are expected at a later stage following a heart attack?
Well, there are certain complications that arise at a later stage following heart attack. In the condition called aneurysm, a scar tissue builds up on the damaged heart wall, resulting in blood clots, low blood pressure, and abnormal heart rhythms. In the condition called pericarditis, the lining of the heart becomes inflamed, causing serious chest pain. Angina occurs when there is not adequate oxygen to reach to the heart, causing chest pain. During congestive heart failure, the heart beats very weakly, leaving a person feeling exhausted and breathless. In the condition called edema, fluid accumulates in the legs and ankles, causing them to swell. Loss of erectile function is caused by a vascular problem. Loss of libido or loss of sexual drive happens, especially in the case of men. Question 26. You hear a discussion between a doctor and a nurse about uterine fibroids.
Hello, doctor. What are uterine fibroids?
Well, uterine fibroids are benign tumors that may grow in various parts of the uterus of a woman. Intramural fibroids are the most common type of fibroid that appear within the muscular wall of the uterus. Intramural fibroids can grow larger and stretch the womb. Subserosal fibroids form on the outside of the uterus called the serosa, and may grow large enough to make the womb appear bigger on one side. Submucosal fibroids bulge into the uterine cavity. Pedunculated fibroids are attached to the uterine wall by a stalk-like growth called a peduncle, which is the main difference between pedunculated fibroids and other fibroids. If a pedunculated fibroid forms in the middle muscle layer or myometrium of the uterus, then it is called pedunculated submucosal fibroid, and if it forms outside the uterus, it is called a pedunculated subserosal fibroid. Question 27. You hear a discussion between a doctor and a nurse about acquired digital fibrokeratoma.
Hello, doctor. What is acquired digital fibrokeratoma?
Well, an acquired digital fibrokeratoma is a benign tumor usually occurring on the fingers and toes, which is an uncommon condition often seen in middle-aged people. Usually the tumors have a dome-shaped appearance, but can also look like elongated projections in some cases. Acquired digital fibrokeratoma lesions are usually isolated, but are also associated with other tumors, in very rare cases. A type 1 acquired digital fibrokeratoma lesion is dome-shaped and has a dermal core that is made up of a thick, intertwined bundles of collagen, which are typically oriented along the lesion's vertical axis. There are numerous capillaries, thin elastic fibers, and fibroblasts between the bundles of collagen. The type 2 acquired digital fibrokeratoma lesions are less common. Although they appear similar to type 1 tumors, histologically, they are typically tall and also have a considerably higher number of fibroblasts and fewer elastic fibers. A type 3 acquired digital fibrokeratoma is very rare, and the tumors are fluid-filled and have fewer elastic fibers. The lesions can be flat to dome-shaped. Question 28. You hear a discussion between a doctor and a nurse about pelvic organ prolapse.
Doctor, what is pelvic organ prolapse?
Well, pelvic organ prolapse refers to the condition in which one or more of the pelvic organs suffers descent from their normal position in the pelvis. It may be congenital, or acquired defect, or weakness in the normal pelvic supporting structures. The anatomical categorization describes which organ is primarily involved in the descent. Urethral involves the anterior vaginal wall, and urethra descend into the vaginal opening. Cystocele involves descent of the anterior vaginal wall and bladder. Cystourethral involves the prolapse of the bladder and urethra along the anterior vaginal wall. Uterovaginal prolapse involves the descent of the uterus, the cervix, and the vaginal vault. Enterocele prolapse of the posterior uppermost part of the vagina with loops of small intestine that have accumulated inside. Rectocele involves descent of the lower posterior wall of the vagina and the rectum which bulges into it. Question 29. You hear a discussion about hematuria.
Hello, doctor. What is hematuria?
Well, hematuria is a health condition that is identified by the presence of blood in the urine. Microscopic and macroscopic are the two major classifications of hematuria. The different types of hematuria categorized based on the cause are: infective hematuria is caused due to pyelonephritis, cystitis, or urethritis. Stones-related hematuria is caused due to staghorn calculi, calcium stones, or uric acid stones. Trauma-related hematuria is caused due to pelvic trauma, renal injuries, or foreign bodies. Renal hematuria is caused due to immunoglobulin A nephropathy, hereditary nephritis, medullary sponge kidney, or thin basement membrane diseases. Latrogenic hematuria is caused due to recent endoscopic procedure, transrectal ultrasound, traumatic catheterization, radiation, indwelling ureteric stents, renal biopsy, extracorporeal shockwave lithotripsy. Benign hematuria is caused due to strictures, renal masses, or benign prostatic hypertrophy. Malignant hematuria is caused due to prostate acinar adenocarcinoma, or renal cell, transitional cell, squamous cell, or urothelial cell carcinoma. Question 30. You hear a discussion about types of collagen and associated disorders. Question 31. You hear a discussion about types of collagen and associated disorders. Question 32. You hear a discussion about types of collagen and associated disorders. Question 33. You hear a discussion about types of collagen and associated disorders. Question 34. You hear a discussion about types of collagen and associated disorders. Question 35. You hear a discussion about types of collagen and associated disorders. Question 36. You hear a discussion about types of collagen and associated disorders. Question 37. You hear a discussion about types of collagen and associated disorders. Question 38. You hear a discussion about types of collagen and associated disorders. Question 39. You hear a discussion about types of collagen and associated disorders. Question 40. You hear a discussion about types of collagen and associated disorders. Question 41. You hear a discussion about types of collagen and associated disorders. Question 42. You hear a discussion about types of collagen and associated disorders. Question 43. You hear a discus
Doctor, can you explain different types of collagen and associated disorders?
Well, there are about 29 genetically distinct collagens present in animal tissues. Collagen types 1, 2, 3, 5, and 11 self-assemble into D-periodic cross-striated fibrils. Here, the D is about 67 nanometers, and there is characteristic axial periodicity of collagen. Type 1 collagen is found throughout the body except in cartilaginous tissues. It is the main component of bone. It is also synthesized in response to injury and in fibrous nodules and fibrous diseases. Type 2 collagen is the main component of cartilage. It is also found in developing cornea and vitreous humor. These are formed from 2 or more collagens or copolymers rather than a single type of collagen. Type 3 collagen is found in the walls of arteries and other hollow organs and usually occurs in the same fibril with type 1 collagen. Type 4 forms the basis of cell basement membrane. Type 5 collagen and type 11 collagen are minor components of tissue and occurs fibrils with type 1 and type 2 collagen respectively. Type 5 forms cell surfaces, hair, and placenta. This is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 through 42, choose the answer A, B, or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1. Questions 31 to 36.
You hear the monologue of a physician giving a lecture on the different types of non-Hodgkin's lymphoma.
You have 90 seconds to read questions 31 to 36.
The 2 main categories of lymphoma are Hodgkin lymphoma and non-Hodgkin lymphoma. Non-Hodgkin lymphoma is a large group of diseases with different symptoms, treatments, and outcomes. The appropriate name of the type of non-Hodgkin lymphoma may include a number of descriptive terms that can be difficult to understand. Lymphomas arise from lymphocytes, a type of white blood cell, which are of 2 types, T cells and B cells. Both help in killing infectious agents, however, in slightly different ways. Based on the type of lymphocyte turned into the cancer cell, the patients may have a T cell or a B cell lymphoma. B cell non-Hodgkin lymphoma is the more common type. There are many different types of B cell and T cell lymphomas, each behaving in a different way. Pathologists performing biopsy of the tumor define the cancers in terms of grade. High-grade lymphoma cells look quite different from normal cells. They tend to grow aggressively. Low-grade lymphomas have cells that look much more similar to normal cells and multiply gradually. Intermediate-grade lymphomas fall somewhere in the middle. The behavior of these types is also described as indolent and aggressive. What the pathologist describes as a high-grade or intermediate-grade lymphoma usually grows fast in the body, so these two types are considered aggressive non-Hodgkin lymphoma. Surprisingly, aggressive non-Hodgkin lymphoma often responds better to treatment, and many people with aggressive non-Hodgkin lymphoma are cured if they are diagnosed early. The most common kind of aggressive lymphoma is diffuse large B-cell lymphoma. On the other hand, low-grade non-Hodgkin lymphoma grows gradually, and these lymphomas are therefore called indolent non-Hodgkin lymphoma. This group of non-Hodgkin lymphoma doesn't give rise to too many symptoms, but they are also long-standing and are less likely to be cured. The most common kind of indolent lymphoma is follicular lymphoma. At times, indolent lymphomas can transform into more aggressive. The majority of lymphomas are nodal lymphomas. That means they originate in the lymph nodes. However, it is possible for lymphomas to arise from anywhere else. When the lymphoma is mainly present in nodes, it is called nodal disease. Occasionally, most of the lymphoma may be in an organ that is not a part of the lymph system, such as the skin, the stomach, or the brain. In such condition, the lymphoma is referred to as extranodal. Therefore, nodal and extranodal refer to the primary site of the disease. A lymphoma can develop in a lymph node and then involve other parts at a later stage. However, in such a case, it is still considered a nodal lymphoma, but is said to have extranodal involvement. In follicular lymphoma, the cancer cells arrange themselves in spherical clusters called follicles. In diffuse non-Hodgkin lymphoma, the cells are spread around without any clustering. Most of the time, low-grade non-Hodgkin lymphoma looks follicular, and intermediate or high-grade non-Hodgkin lymphoma looks diffuse in biopsy. Non-Hodgkin lymphomas are also described as common or rarer based on the statistics of the new cases every year. Now look at Extract 2. Questions 37 to 42.
You hear a medical podcast on the guidelines for coping with Prader-Willi syndrome.
You have 90 seconds to read questions 37 to 42.
Hello, Mrs. Araceli. I am Dr. Gonzalez.
Hello, doctor. I would like to tell you something about myself.
Yes, please.
I have been married for 55 years and we have 3 children. The second child, who was born in 1964, had every kind of physical problem and was in the hospital for 10 months. However, we did not have a diagnosis until she was 4.5.
What does the diagnosis indicate?
Prader-Willi syndrome.
Prader-Willi syndrome?
Yes, it had a severe impact on my child in very complicated ways, mainly the damage of the 2 primary areas of the brain, the deletion of chromosomes 15 and hyperplasia. She is always feeling and thinking about food the whole time, akin to the feeling of starvation, and she never has the feeling of satiety. So this affects her daily life in an extreme way, and her tolerance level and the temper control, which is affected greatly.
Over the years, you would have experienced the communication skills of your doctor a lot. What is your impression in general?
We've been very fortunate for not having any bitter experience over the diagnosis. However, later on we have realized that he had suggested blood tests for her that were not actually required. That was the only bitter experience we had.
Actually, Prader-Willi syndrome is a complicated genetic condition that severely impacts several parts of the body. In infancy, this condition is identified by weak muscle tone called hypotonia, difficulties in feeding, poor growth, and delayed cognitive development. The patients develop an insatiable appetite right from the childhood, resulting in chronic overeating called hyperphagia and obesity. Some patients with Prader-Willi syndrome, especially those with obesity, also develop the most common form of diabetes called type 2 diabetes. The patients will typically have mild to moderate intellectual impairment and cognitive disabilities. Behavioral problems are very common, such as stubbornness, temper outbursts, and compulsive behavior. Sleep abnormalities can also be seen in the patients. Distinctive facial features such as almond-shaped eyes, triangular mouth, and a narrow forehead. Short in height, small feet and hands. Patients even have light-colored hair and unusually fair skin. Male as well as female patients will have underdeveloped genitals, delayed or incomplete puberty, and infertility is also common.
So is there any chance of curing Prader-Willi syndrome, doctor?
Yeah, but it's a lengthy process. Parents can enroll infants with Prader-Willi syndrome in early intervention programs. However, even if the diagnosis is delayed, treatments are available at any age. Therefore, for the patients with Prader-Willi syndrome, the types of treatment depend on the patient's symptoms. You can adopt any of the following steps that are suitable for the patient. Can use nipples or tubes for the patients with feeding difficulties. Special nipples or tubes have to be used for several months to feed the child with feeding difficulties, to make sure that the infant is fed completely and it has proper growth. The healthcare provider will monitor weight, height, and body mass index periodically to ensure proper growth. By supervising the daily food intake, the parents could prevent the overeating behavior that starts from 2 to 4 years of age. This will minimize food hoarding and prevent rapid weight gain and obesity. Growth hormone therapy has to be performed to increase lean body mass, mobility, and height. To reduce fat mass and improve movement and flexibility from infancy through adulthood. If the growth hormone therapy is given early in life, it may reduce or prevent behavioral difficulties. In addition, this can help improve speech, cognitive ability, abstract reasoning, and often promote information to be processed very quickly. It also improves sleep quality and resting energy expenditure. Growth hormone therapy is usually started during infancy or immediately after the diagnosis, and often continues during adulthood at 20% to 25% of the recommended dose for the patient. Many patients have trouble getting their eyes focused together. Such patients should be referred to a pediatric ophthalmologist. If necessary, an orthopedist will evaluate and treat the curvature of the spine called scoliosis. Sleep disorders are very common in Prader-Willi syndrome patients. Treating a sleep disorder in an early stage would help improve the quality of sleep. Muscle weakness is a serious issue among the patients with PWS. For children younger than 3 years of age, a physical therapy is essential to increase muscular strength to achieve developmental milestones. Generally, the patients have difficulty in controlling their emotions. Therefore, a behavioral therapy could help to control anger, obsessive-compulsive behavior, and stubbornness, including an obsession with food. Medications, such as serotonin reuptake inhibitors, may reduce obsessive-compulsive behavior and also help manage psychosis.
Thank you very much, doctor. That's been really useful. Thank you.
Thank you, Mrs. Araceli.
That is the end of Part C. You now have 2 minutes to check your answers.